So welcome to everyone to Stanford University. On behalf of our Department of Ophthalmology at the Byers Eye Institute, we welcome everyone here on campus. On behalf of the Stanford Cancer Institute, we welcome you here. This is the Alumni Center. As you can tell, Stanford has some pretty swanky alumni. But we've been fortunate to be able to enjoy these facilities as well. And I hope you have a chance in the midst of a very busy weekend to enjoy the beauty of the campus and kind of get the feel of Northern California, and please come back to visit us. That would be great. So as the program goes today, I'm going to start with a little bit from the eye perspective, and we're going to move on to some of the systemic perspectives of dealing with ocular melanoma. And Grant gave me a really interesting bit of information that there's about 20% of the audience here today who are recent diagnoses of ocular melanoma, but within the past year or two. And that's very different from some of the others who have been, involved in understanding the disease, fighting the disease, conquering the disease over a much longer period of time. So the purpose of my talk is not to make things too simple or too advanced, but hopefully just right. And it allows us to move into a conversation that we're going to have with some of our experts here today to kind of delve into some more detailed questions as you may have them going forward. So let's begin. And we'll talk about uveal melanoma in 2017, an overview of the current disease and then the future directions that we have to look forward to. So some of my disclosures, and what we're going to focus on today are four main topics. One is diagnosis. How does the ocular oncologist make the correct diagnosis for the patient? The second is to review treatment options that we have available to us, and focusing specifically on radiation treatment options that are available. One of the hot topics, of course, is the role of genetics, understanding what that means and what are our options for genetic testing, how we obtain biopsy specimens, and finally, new therapies that are on the horizon for treating the eye. We'll be talking about newer therapies for systemic disease as the day goes on. So it all starts with a nevus. So this is a mole that we can see in the eye. About 6% of the Caucasian population has a nevus. About 1 in 8,000 or 1 in 9,000 can transform into a melanoma. That might be the same odds of winning the California State Lottery or getting struck by lightning. But we know, as someone said, I'm not a statistic, that's true. If it happens to you, then it's 100% of the time. But we know that the relative incidence is relatively uncommon. And the lifetime risk of growth of any nevus, not into a melanoma, but growth in general, is about 1%. So they tend to grow. When we look at it clinically, we look at several features that tell us that this is a nevus and not a melanoma. The height's not very thick. Sometimes they're flat, sometimes they're just a little bit elevated. It doesn't tend to have a lot of fluid leaking from it, so it doesn't show a lot of biological activity. It tends to have age spots, and the line that I love to say is that it's the only time I can tell a young lady or an older lady or a younger gentleman or older gentleman, it's good to have age spots, because that means that this has been there longer than you and I both know, and that's a good sign. And the key is to have eye exams, to have multiple eye exams on a routine basis, and if there is something that's abnormal, we encourage your eye doctors to take pictures so that we can follow them going forward, because you never know what it really looks like unless you have something directly to compare to. Now this looks a little bit worse than that little nevus, right? This is a frank choroidal melanoma, which we know is the most common primary intraocular tumor that can develop. And about 6 patients per million in the United States, so it's about 2,500 new cases a year in this country. They tend to occur in older Caucasian individuals, and everyone always asks, what's my risk factor? And I tell people, you did nothing to cause this. It's not like smoking or other things or factors. We think maybe exposure to sunlight in some northern European populations, other kind of associations, but really, in truth, we don't really know that anyone can do anything to cause these. We know that a choroidal melanoma differs from a nevus in its clinical appearance. We know that it has a certain size and thickness and height that we can measure. We know that there can be fluid that leaks from these that can cause some of the symptoms that people will have that can appear to be like a retinal detachment. There can be orange pigment that grows on the surface. That's usually an indication of active metabolic activity within the tumor itself. And we're also concerned with the tumors that are located closer to the back of the eye and the optic nerve, probably because those are the ones that are going to be more easily detected and more symptomatic. But those are all known to be risk factors. We know that the rate of melanoma, of uveal melanoma, is pretty stable over a multi-decade period of time, unlike other types of melanomas which are increasing, cutaneous melanoma, even conjunctival melanoma. We know that it's a disease of older individuals, but the youngest child I've treated was 2 years old with a melanoma of the iris, and I've had discussions just this week with a 92-year-old woman who we've diagnosed with a melanoma. So it's an equal opportunity effector of people. So it's not any one particular group or not. Now sometimes it gets a little technical because there are various variations in how this disease manifests itself. So sometimes we can see conditions with elevated eye pressure. Sometimes we can see abnormal blood vessels growing. Sometimes we can see cataracts that form. You think a cataract's not that dangerous, but if in association with how the melanoma might be pressing against the lens, that could induce cataract formation a little bit more accelerated. And these are all clinical signs and clues that your ocular oncologist will be able to cue in on. So accurate diagnosis impacts a lot of things. So first, it impacts how we counsel our patients and how we make the correct decision. So that might be something as simple as observe something or treat something. That's a big fork in the road, but being able to diagnose it accurately makes that difference. It might make the difference on what type of treatment we choose for an individual patient. Might we go to radiation? Might we think about chemotherapy, resection of the tumor, or removal of the eye? So if you haven't made the right diagnosis, you can't make the right treatment decision for your patient. And finally, the accurate diagnosis helps us to give patients information about systemic prognosis. So what is the prognosis for that tumor? And that gives us opportunities for earlier treatment, better detection mechanisms, and maybe even entry into clinical trials. So all of this kind of plays into, did we make the right diagnosis? We know that Carol Shields has been very instrumental in giving us various clues to whether a lesion may or may not be melanomas. Others have contributed to this literature as well. And we know that of these clinical features, having more than one, more than two, more than three of these increases the likelihood that a lesion is going to grow. It doesn't automatically diagnose a melanoma, but it does give us a clue that these are at risk for growth, and that makes us concerned that this is going to be a melanoma rather than just a benign nevus. But the key is there's not one magic risk factor. So I can't look at that list and point and say, this is the one that automatically guarantees that it's a melanoma. So I always take that in a little bit of, you have to take it with a little bit of salt in terms of how you put the whole clinical picture together. And I think that that's what we've gotten better at. One of the ways that we do this is using multiple imaging technologies in the clinic to help us decide what it is that we're dealing with and what it is that we're seeing. It's helpful to get this information because if you're not sure it's a melanoma or it may be an early nevus or a suspicious nevus, you have that baseline information to then follow your patients going forward to see if there's any change. Because sometimes it's a snapshot. You see a patient for the first time today, you get this picture of what's going on, and you don't know, has this been there forever? Has this just come up yesterday? But if you see them again in a short period of time and there's a change, then you have something to base that reference on. And we use several different modalities. We take pictures of the eye. We use ultrasound. We use a technology called OCT, or optical coherence tomography, to give us kind of a live time biopsy, cross-sectional of the eye, and autofluorescence. Color photos are to me, like the old-time standard of what we need to use to be able to get a good sense of it. It gives us a good sense of where the tumor is located, whether there's features on the surface of the tumor that helps us to make these diagnoses, and most importantly, it allows for serial documentation. A lot of times now when people go to their lens crafters or to visit with their optometrist, they're given an option. If you don't want your eyes dilated today, for $50, we'll take a picture of your eye. And so, and a lot of times, I prefer the eyes dilated and you get a good look, but if nothing else, at least there's a picture of something. The worst is, and we were talking this morning, the worst is people will go to get their eyeglasses checked and they'll defer getting their eyes dilated. And I think everyone in this audience knows that that would be a big mistake. So, one thing that we really encourage is a eye exam at least annually for everybody. That's what our academy recommends, and to make sure you get your eyes dilated. It teaches us so much. Ultrasound, we know, is an important tool when you come into the clinic. It gives us good ultrastructural identification of what we see, even with large melanomas, but even for small melanomas, it gives us important designation of what the tumor is made of internally by an ultrasound characteristic, and also the thickness or the height of the tumor. One of the technologies that we've been very interested in is using optical coherence tomography, or OCT. What this does is it takes the eye, and the computer kind of slices your eye in half and then turns it on side, and so we can see kind of the thickness of the retina and the layers below it and the layers above these tumors as well. So it gives us kind of a live ability to look at, almost like under a microscope, what the eye is looking at. It gives us a lot of information about the thickness of the tumor and the thickness of the retina overlying it. We're limited to how large these tumors can be for us to get this information, about 2.5 millimeters thick or smaller, but it really gives us some important information on alterations within the retina overlying it, whether there's fluid, which we talked about as an important risk factor, and also the thickness of the lesion itself. And one of the tips that I always make a point is that just because we say fluid is an important risk factor, not all fluid on these tumors are necessarily dangerous or a sign of malignancy. And it's being able to differentiate that instead of saying all fluid is bad. Not all fluid may not all be good, but it may not be malignant either. One of the other things that we've been able to do now is to kind of use multiple modalities to help us decide what we're seeing. Is it a problem or is it not? And we call this multimodal co-localization, where we can use various imaging technologies to find exactly what we're looking at in one image and then confirm it or clarify it by looking at other images. All of this helps us to get a much better sense of the overall appearance of this. So multimodal imaging really helps us to better understand the accuracy of the diagnosis. So moving forward, now that you've made the diagnosis of melanoma, what are the current treatment options available for our patients? So when we look at the options that are available, and we'll run through these, the key is that it's really a coordination of treatment, not just by your ocular oncologist, but with the medical oncologist, the radiation oncologist, the interventionalist. It's a team approach to decide what is the best treatment right now, and how would you plan that treatment as it's going forward and things evolve over time. And this is a perfect example of customized treatment for each patient. There's not just one thing that everyone has to go and do. It really has to be individualized for your patient. So if you look at what determines treatment options for a patient, it's not just one thing. It's the characteristics of the tumor itself. Where is it located? How big is it? Has it grown, or is it growing rapidly, or do we know that it's grown at all? What is the visual potential for this eye if we're trying to save the eye? What is the systemic health of the patient? And what are patient factors that go into it? Just because I think the best treatment is X, Y, and Z, my 92-year-old patient who I met this week, says, "Doc, I'm 92 years old. Do I really need to go through all that?" That's a very different conversation than if he were 42, 52, 62, and maybe 102. So it's a very different conversation for every patient. And I think we have to respect, patient wishes as well, and where they want to go with it. And what's amazing is that with the internet, patients are incredibly sophisticated and in great understanding of what's going on in many cases. So it's a great conversation to be able to have. Sometimes we can observe these suspicious lesions, though very closely. Enucleation or eye removal is an important option to discuss. Radiation therapy, laser therapy, and sometimes local resection. And finally, we'll talk a little bit about the role of biopsy, which is important in those cases that A, you're not sure what this tumor is and you want to confirm that it's a melanoma or not, and also to obtain information for genetic testing. We'll talk a little bit about these main modalities. The first is what we call transpupillary thermotherapy, or TTT, which is a type of hot laser that basically burns the tumor in the clinic. It's a specific type of laser that's used. We find that for smaller tumors, so less than about 3.5 millimeters in thickness, It has been used fairly successfully as a primary modality. It's nice to kind of shrink the tumor down. It's not 100% in terms of its effectiveness, and we know that about anywhere from 5 to 30% of patients, based on different studies, may have need for either repeated treatments or there could be reactivation of the tumor afterwards. But in some patients, it may be helpful. Sometimes after you've had radiation treatment for specific tumors that show signs of relapse or kind of tricky locations, your ocular oncologist may add the laser on top, and we call that a sandwich technique, where radiation comes from one side and the laser comes from the other, and you try to squish this thing down completely. So it can be used in various modalities. Enucleation is the procedure in which we completely remove the eye altogether. Now that sounds kind of extreme, but we know that it is the treatment that allows 100% the elimination of the cancer from the eye region itself. So it's an important treatment. It's tried and true and tested. And for some patients, because of the size of the tumor or the extensive nature of it, and even their own preference, enucleation is the right answer. And there are some people that will come to you and say, you know what, doc, I was born with 2 eyes and I'm leaving with 2 eyes. I do not want my eye removed. And others will say, doc, I was born with 2 eyes. I got one that's got this cancer in it. Get it out. And I think that decision is very individual, and I think that no matter what data I can give you or not for whatnot, again, that's where we respect the patient's participation in the decision, and often that's a very personal and also a medical necessity to do that as well. We know that removing the eye removes visual function, but often some of these eyes are already compromised in visual function, so it's not a difficult, kind of gain-loss situation. Peripheral vision's there, and cosmesis is a concern for many, and we're going to have actually one of the really awesome local ocularists coming tomorrow to talk about that process of rehabilitation with ocular prostheses. So that'll be very interesting for you all to participate with. And finally, radiation therapy is what we'll talk about. And there's different ways that radiation we use. Radiation is directed from a source to the tumor itself. The neat thing is that radiation kills rapidly dividing cells, and by definition, cancer is a situation where there's rapidly dividing cells. So the damage that's imparted by radiation therapy is to these cells that are rapidly dividing, and it can be delivered in many methods. External beam radiation, which we use mainly for kind of non-melanomas, but specifically proton beam radiation, which is very actively used in this region here in Northern California and other parts of the country, and localized radiation, which is what we call plaque brachytherapy. As I mentioned yesterday in my comments during dinner, we're really fortunate in the Northern California area, in this little village that we'll call San Francisco and the little hamlet that we'll call the Bay Area. We have a lot of ocular oncologists that have really made some amazing advances in the field. Proton beam therapy, we're lucky in the Northern California area to have one of the 2 most active centers in the United States, other than Boston, and now there are many more centers that are coming up with proton therapy. And Devrin Char from the Tumori Foundation in San Francisco has been one of the U.S. pioneers in the role of proton therapy. This is a specific type of external radiation that's applied, that's marked around the tumor so that it's more directed. The interesting part about the physics of proton therapy is that it has a very strong dosing characteristic that allows for controlling the area that the radiation is coming into and minimizing the secondary side effects of the radiation to the tissues around it. So it targets the tumor much better than other forms of external radiation. And the data supports this, and it's used in many cases for very large tumors, tumors that are located close to the optic nerve or the fovea, but can be used for really, as any primary treatment for ocular melanoma. So we're appreciative of Dr. Char and his contributions. Plaque brachytherapy is a form of localized radiation where the radioactive source, the seeds themselves, are placed right on the outside of the eye, and it's sewn in place. We know that it delivers what we call confluent dosing, or very kind of steady dosing to the eye and the tumor. It's custom designed for your tumor, so based on the size of it and its location. Usually it's sewn in place and it stays there for about anywhere from 3 to 5 days while you're having the treatment. And now with some of our more advanced planning software, we can get very, very detailed in exactly how we design these plaques to sit on the eye and how the radiation dosing comes forward. So we've actually learned a lot in this. So let's say this is an eye and that big black thing in the back is the big bad melanoma. So when we take you to surgery, we place this disc, which looks like a stack of gold quarters, on the outside of the eye, directly behind where this tumor is located. The radiation kind of works like a force field, and it kind of goes into the eye, and it basically attacks all of those cells and destroys them. And over time, we see the gradual shrinkage of the tumor. What you're not seeing is this force field extending into someone's brain. They don't lose their hair. You don't have other side effects that you hear about with patients that have radiation from other types of cancer. So it's very, very focused treatment. This is what it looks like. This is what we call a dummy plaque. They're not that unsmart, but they're just dummy plaques, which is what we use at the time of surgery so that we can avoid excess radiation manipulation. And this is what the active plaque looks like. That's made out of gold, actually, so we have to protect it. It's like very sacred. And then this is the actual little grains of rice-looking thing, metal rice. Those are the radioactive seeds themselves. So with brachytherapy, it's like this whole big event when we do the surgery. It's all locked in a box, and there's like 2 keys, and everyone keeps it safe because you don't want this thing like falling all over the place. So it's pretty well protected. So that's what the actual disc would look like before we implant it. So one of the questions, and maybe we'll touch on this in the panel, is that are protons better or are plaque therapy better? Is one better than the other? I think the bottom line is that they're both incredibly effective in treating ocular melanoma. So I think that if you had one treatment, not the other, you're not missing out on anything. There's theoretical advantages to each, and sometimes you have to customize that, and I think that's the key to what I'm going to tell you. It's a customized approach based on what your tumor requires. And there are theoretical limits to both. I'd say that, is this the best treatment that we ever have or going to have for ocular melanoma? I don't know, but it's one that's been around and tested, and we're all very comfortable with that for a long time. We'll end with talking about metastatic disease. It's what we don't want to have to deal with, but it's something that as a community we need to be as informed and educated about it, because knowledge is power. The more we know about it, the more we can better address it. We know that there's an unacceptable rate of patients who develop metastatic disease. Typically, the statistics tell us within 2 to 4 years after diagnosis, but we all know that it can occur really at any time, even more than decades after the initial diagnosis and treatment. We know that the liver is the primary target of these metastases. We know that the lungs can also follow, and then there's a list of other strange places that you wouldn't expect but can occur as well. When we try to figure out prognostic factors, predictable factors that we can try to determine which patients may develop metastases, there's different ways that we can do this. What we had before modern technology are clinical features, good observations, measurements to try to determine which of those clinical features are more or less likely to cause trouble. The second was looking at these tumors under the microscope and features within the tumors themselves that might give us information about prognosis. Then we moved into the era of cytogenetics, so looking at chromosomal abnormalities within the tumors themselves that make high or low risk for metastasis more evident. And finally, the role of gene expression profile testing, which we'll talk about as well. But all of these have kind of been in evolution as we've gone, and a lot has happened within the past few years, and credit to folks like Sarah Copeland, Bertil D'Amato, Bill Harbour, that have helped us to better understand some of these molecular events that take a nevus and then help that nevus decide, do I become something more sinister like a melanoma, or do I stay as a nevus? And these are a series of mutational events, strikes of lightning if you would, that can change the course or the fate of these various melanomas. The problem is sometimes we find these after it's already happened. And we're kind of going backwards to say that, well, this is probably how it got here. What we still haven't figured out is if we were able to find a nevus just in and of itself that looked really small, really benign, how do we know the destiny of that nevus going forward? And I think that's part of the challenges that we're trying to uncover. Michael Cedar is an ocular oncologist and a retina specialist at the Permanente group here in San Francisco, and recently published an excellent review of the molecular prognostic testing available for uveal melanoma, and we'll be listening to Dr. Cedar later today as well. Genetic testing now for melanoma has become the new standard, and I can't say that this was the standard 5 years ago, 10 years ago in all centers, but I think nowadays we're understanding the importance of it. It increases our knowledge of the genetic changes within ocular melanoma. It's important for patients so they can understand or better understand their prognostic risk, and maybe gives us entry into clinical trials and to try to customize the testing that we do for our patients. Armin Afshar is an assistant professor of ophthalmology at UCSF and an ocular oncologist, and he's spoken widely about the role of doing biopsies to obtain tissue for genetic testing. And how we do that is either kind of going from the outside of the eye or going inside the eye to get the specimen. And I'll show you a video here. Not trying to gross you out, but I want you to see how we go into the eye with very small instruments to obtain tissue samples of the melanoma. Do you guys have breakfast already? So here we're going in with small instruments so we can clearly visualize the tumor. This tumor is not very thick. We're not talking about something like, this big. We're talking about something just millimeters in size. So it takes a lot of precision to be able to go in and enter that tumor, get the specimen, and keep the eye intact. But we're able to do that with a lot of instrumentation that we have available to us. And typically these biopsies are done right before radiation treatment at the time of eye enucleation, but sometimes before the treatment's even decided on if you're trying to figure out what it is. So the staging can be there. There's 3 types of genetic testing that we're going to talk about today. One is gene expression profile testing. The second is chromosomal-based or cytogenetic testing. The third we'll touch on briefly is kind of newer technologies or next-generation sequencing, which our colleagues from UCSF are exploring with a novel platform. And finally, how do you combine the known information about clinical patterns plus genetic testing to give an even more enhanced bit of information? Gene expression profile testing has been able to take RNA from within the tumor and decipher patterns of gene upregulation and downregulation. And basically what that means is that you take a whole bunch of samples that are tested through, and then you try to decide in certain patients which ones kind of give a signal that tell us that it's more or less likely for metastasis. And 3 groups of tumors have been identified that are called class 1A, that are the highest percentage of patients with the lowest risk of metastatic risk. Class 1B are kind of an intermediate risk, and then class 2. This has all been corroborated by a prospective study through the Collaborative Ocular Oncology group, which we were a part of. Peter Hovland, who's the medical director here at OMF, was also a part of, and Bill Harbour led the study when he was at Washington University. Castle Biosciences, who's kindly been a sponsor of this meeting today, allows us to send this test in to their facility. What it allows is by a small sample of a tumor, we can then get an answer that tells us class 1A, class 1B, or class 2. There's a new modifier to this, which is a specific antigen called PRAME, P-R-A-M-E, that helps to modify the risk as well. So when the test was first done, there was only 2, class 1, class 2 choices that you can get. Now there's 3, 1A, 1B, and 2. Now there's a modifier to that, PRAME or no PRAME. What this tells us is that we're learning something every day about how these tumors work. So as much information as we can gather and carry forward will help us to ultimately come up with answers to our patients' specific situations. We know that the prognostic information is provided to the patient based on the genetic information available. We have this now corroborated by several different studies. And we know that for the majority of patients, they end up being class 1A, which is the lowest risk, but it's our class 2 and class 1B patients that we're trying to get a lot of more information and options for. The chromosomal testing that's available, again, through another company that's doing incredible work called Impact Genetics. So Impact Genetics provides a service, again, that gives us information about the main chromosomes that are affected in ocular melanoma. So they test several of these with a lot of advanced testing modalities that have been validated by many independent groups. It also gives information about some of these modifier genetic mutations that we have learned more about more recently that increase or decrease risk. And they give us a nice little individualized prediction model that kind of takes into account some of the genetic information that is derived and offers the patient information going forward. The company also provides opportunity for genetic counseling that you can call in and schedule so you can better understand the information that comes in on your sheet. So that's another service that's available. How do we talk about personalized risk? So this is the kind of the holy grail of medicine, where you take your genetic factors, your clinical factors, and you want the answer just for you, not a population of 100 or 1,000 people. We have to thank Professor D'Amato in his work when he was in Liverpool and also continuing here at UCSF, who's developed with his team this risk modeling prognosticator. This is actually free and available online, which is an incredible resource called the LUMPO program, where you can enter an incredible amount of personalized information about the patient, about you, your tumor, any histology information, puts it in with a lot of very fancy computational work, and then in a really elegant but simple way kind of gives a risk assessment profile that can be more customized to you based on a lot of information from many other patients that are similar. So this is one of the ways we're talking about customizing risk. Finally, what about screening for metastatic disease? This is probably a whole lecture in and of itself. We know that the reason is to look for early signs of solid tissue disease in the liver or in the lungs. Imaging the liver is a priority, but also the lungs. But I always tell people we don't look at the brain because uveal melanoma really doesn't go to the brain, which is different from cutaneous melanoma. A lot of ways to image: MRIs, PET scans, CTs, ultrasounds, chest x-rays, blood tests, a lot of things that you can do. The frequency will also depend on your particular doctors that you're working with. The key is there's no clear established standard, so everyone's going to be a little different, which is confusing because if you talk to your neighbor, when's the last time you got an MRI? I never got an MRI. Got one yesterday. So it's going to be a variable story. So this is kind of taken from a slide from the folks at Castle, but I've modified it a little bit in that in general what we're kind of going towards is low intensity versus high intensity screening. So if we can determine low genetic risk by any means that you want and clinical features, then maybe you can screen patients less frequently. If you have high genetic risk disease, that's when you screen them more frequently. And finally, identifying patients with higher genetic risk disease may be those patients that would be most applicable to go into clinical trials that may be looking for ways to prevent disease. I will end with some future directions because my time is up. What we expect in 2018 and maybe a little bit into the future is improved genetic diagnoses, improved ways to get those small tissue samples for biopsies, strategies to reduce radiation-related side effects called radiation retinopathy, and trials that might take patients that don't have metastatic disease that we predict may develop it and to have effective treatments to prevent it. And then finally, I wanted to touch on a flyer that you have there with a company that you're going to hear a lot more about called Aura Biosciences. So they've developed really a first in class designation for a type of treatment in which they take a viral particle that they've engineered. This is like super fancy, genetic engineering here. And they attach a special kind of think of it like a suicide switch to that viral particle. They inject it into the eye. it goes directly to the eye tumor, and they have a special laser that doesn't burn the eye, but just activates that switch on that particle, and it destroys the tumor. At least they've found that in small animals. They've started a clinical trial. So on the animal side, you can see the top deep purple is the tumor that hasn't been treated, and that kind of light purple is all dead tumor. So really promising. No surgery, nothing in the operating room, all done in the clinic. So a very different paradigm. So now they're looking at more clinical trial information. So I think that will be something we'll all be learning more about as we go forward. So with that, I thank you for your attention.